Hi, good afternoon, everyone. My name is Nainesh Parikh, and I am an assistant member in the Department of Diagnostic Imaging and Interventional Radiology. Thank you for having me here today. I want to thank Dr. Michael Pock and Dr. Brandon Manley for asking me to join the Kidney Cancer Educational Symposium today. Today, I'd like to talk about IR updates, interventional radiology updates, biopsy, ablation, efficacy, and complications of both. I have no disclosures pertinent to this. And today, the learning objectives are the following: indications for efficacy and complications of image-guided biopsy renal masses, and indications for efficacy and complications of percutaneous ablation of renal masses. A little bit of background. As most of you probably know, up to 60% of RCC is diagnosed incidentally. The larger the mass, the higher the likelihood of malignancy, with up to 30% of masses less than 2 centimeters demonstrating benignity. 4 centimeters and 7 centimeters are important cutoffs to remember because this is the difference between stage 1A and stage 1B. I'm sorry, stage T1A and stage T1B. And the algorithm for treatment for each of these differences in size changes slightly. Ablative techniques apply predominantly to stage T1A, but also to stage T1B, depending on the circumstance. So let's talk about biopsy. When should you biopsy? This is always a fascinating question. We think here at Moffitt that here are the following situations under which you should truly biopsy. Suspicion of non-RCC mass, so for example, an extrarenal primary like lung cancer or colon cancer, significant surgical comorbidities, increased patient age, and intention to conduct active surveillance. And there are several reasons for this, but most importantly, if these things will change management, then of course we suggest biopsy. So if the patient decides with their urologist and or interventional radiologist that surgery is not an option depending on the outcome of the biopsy, well then that should be evaluated. There are differences, however, with when to biopsy or not to biopsy and why biopsy is not favored by many of my colleagues. There's a perceived risk of hemorrhage and tract seeding, which we'll go over. There's the question of the ability to obtain final diagnosis, which we really truly refer to as diagnostic yield. There's the question about benignity versus malignancy and whether or not you still might want to treat. I'll bring up the term oncocytoma as an example. And then there's a question around, well, if we do biopsy, are we able to do subtyping and Furman grading? So what are the indications for biopsy? As we talked about before, we operate here at Moffitt under the following. If there's an extrarenal primary, for which many of our patients are actually true, colon cancer, lung cancer, breast cancer, ovarian cancer, all sorts of different cancers. If they have an incidentally found renal mass, we biopsy them. If they have unresectable renal cancer, and therefore any of the molecular markers might make them eligible for trials or immunotherapy, or even for additional immunohistochemical staining for guiding personalized management, we definitely biopsy them. If they are high-risk surgical candidates and we need to ensure that we have RCC, clear cell type, or any other type of RCC, before we subject them to surgical risk, we biopsy them. If they have multiple solid renal masses, if there's possible infection, if there are small hyperdense masses that we can't solve or for which we can't truly evaluate with dedicated renal phase MRI, we biopsy them. And I'll go over this in a few moments, we biopsy prior to or along with ablation, given that ablation is indicated for small renal masses and up to 30% of masses that were ablated are benign. There's a question around Bosniak 3 lesions. And the reason I say that is not because there's a risk of hemorrhage to the patient that's detrimental, but because once you start involving a little bit of hemorrhage into a Bosniak 3 lesion, we feel that the confidence level of diagnostic yield goes down. So because these lesions are cystic, if you start using an FNA or even a core biopsy needle to try to obtain tissue, you'll often induce hemorrhage, and then you won't be able to make a diagnosis. Lastly, I'll just hammer this point home. We at Moffitt think that the appropriate time to perform a biopsy is when results will change management in any significant way. What are the efficacy and complications after biopsy? Well, I'd like to show you this table, and this table shows you an overall meta-analysis of several different prior studies that look at diagnostic performance. And again, remember, diagnostic performance can mean a lot of different things, but overall, if you think about the diagnostic performance as the ability of the biopsy to determine malignant versus benign lesions, and simply divide the category like that, you can see that for the most part, the accuracy for malignancy should be well above 90%. And if you are able to get enough sample, then this should always be the case. Now, that's a logical way of thinking, but I think about it slightly differently. I think that because you know that your diagnostic yield should be well above 90%, then you should strive to get enough sample in order to make that true. And that, I think, is something very valuable. You can see here that the reason you want to do it is the underlying cell type, and the way you do it is the size of the lesion and the needle that you use. Let's talk about complications for a moment. Again, seeding has always been a question that people have asked about, and then significant bleeding. I always bring up that I learned early on in medical school, folks say, you're not truly biopsying an RCC if it's not back bleeding. And I think they're in some ways true. So those are the two risks that people often get concerned about. And let's take a look at the meta-analysis that looks at several prior studies. As you can see here, in these studies, which have been well cited and well published, there has never been a demonstration of seeding. In addition, the bleeding risk, and when they say significant, I'd like to point this out. I thought that this was an excellent definition. Significant means bleeding requiring active treatment, including transfusions or hospital admission, or, for example, angiography and embolization. This number of all comers is about 1%, maybe a little higher. So when you think about the risk of the biopsy, as opposed to the benefit of obtaining not only a diagnosis, but potentially guiding molecular therapy, in almost all cases, if the biopsy is going to change management, the benefits outweigh the risks. And so it is my firm belief that if my colleagues refer a patient for a renal biopsy, assuming that I think that they are going to change their management based on the outcome, I strive to get as much tissue as possible. And it's because of this data. When you use coaxial technique, there has never been a reported case of tract seeding. When you do use coaxial technique and you do it appropriately, the risk of significant bleeding should be around 1%. Again, that risk is real. It should not be neglected, and it should be handled very, very, very seriously. However, as an interventional radiologist, you should also feel comfortable knowing that you should be able to deal with any significant bleeding. And as long as you've got the backup of your colleagues, such as Dr. Pak and Dr. Manley, you should feel very comfortable with this risk. As you can see, up to 2% risk of major bleeding, depending on the study that you see. Less than 1% required embolization, which is significant, meaning very few times, even if there is bleeding, it oftentimes just stops on its own. In the interventional literature, complication rate of 1% is what should be remembered. That means that out of thousands or tens of thousands of biopsies published on, about 1% of the time, we get some sort of quote unquote complication. And I'm happy to give anybody any of these references. Like I said, typically, any of the perinephric hemorrhage is self-limited and subcapsular, and even the perinephric hematoma is usually something that's self-limited and will stop on its own. In terms of seeding, case reports do exist in the literature, but no cases have ever been reported when utilizing coaxial technique. While that's beyond the scope of this discussion, what I'll say about coaxial technique is that it is the technique that should be and is used almost everywhere around the United States. If people are not using coaxial technique, that's an older school way of doing it, which I think would predispose people to potentially seeding and increased hemorrhage. But nowadays, coaxial technique is almost solely used. And if you use coaxial technique, there should never be a case of seeding. And again, it's hard for me to say never, but the literature supports that there's no seeding if coaxial technique has been used. Let's switch topics and talk about ablation for a moment. So the indications for percutaneous ablation, and I won't dive into the differences between cryoablation, which is freezing, and microwave ablation, which is heating, except to say that we use both here at Moffitt, and in fact, I use both heavily in my practice. Just depends on the location of the lesion and the exophytic nature of the lesion. But anyways, for sizes less than or equal to 4 centimeters, I would note the following for the indications for ablation. If a lesion is less than 1 centimeter, but the growth kinetics demonstrate significant growth and the doubling time is less than 1 year, I would suggest ablating. If it's greater than 2 centimeters, given the increased likelihood of benignity for those less than 2 centimeters, we would suggest ablating. If it's predominantly or entirely exophytic, we can hydrodissect structures adjacent to the colon or small intestine. Endophytic masses are still very much eligible, and adjacency to the collecting system and renal hilum are not contraindications due to protective techniques that we can use. You can actually freeze into the collecting system. And in fact, if you wanted to be extra safe, as for example, if you're looking at a low kind of anterior polar mass that may be exophytic and encroaching upon the renal pelvis or the descending ureter, you could actually use catheter installation of warm saline into the renal pelvis and ureter to protect it. Here, I'd like to show you just one simple example. This is a partially exophytic mass in the left kidney, 61-year-old post-total colectomy. We biopsied at the same time. This is the cryoablation, so you can see that the darkness or the dark gray is the ice ball, and it's freezing potentially into the collecting system or into the renal sinus. And in 4-month follow-up, you can see no further enhancement. And this was found to be RCC. An additional one, you can see there's a right renal mass, but in fact, there's a renal mass here that wasn't seen and wasn't called by the outside radiologist. One of my colleagues did a partial nephrectomy, but this was still left in place. I can't blame him because it's very hard if you don't know that it's there a priori. Because the patient had a prior partial nephrectomy and the thinking was it would be very challenging to go back in, I performed a renal cryoablation. You can see it's entirely endophytic. You can see that it's central in nature. And you can see that I was able to freeze directly into the collecting system. And you can see here on the 1-year follow-up, it's entirely gone with no evidence of recurrence. What about sizes greater than 4? Well, we still think that size greater than 4 and less than or equal to 7 and not good surgical candidates can be indications for ablation. When you're getting to 7, it is very challenging, but there are other options. So close to 4 centimeters, you can still perform an ablation with a good result. When it's greater than 4 centimeters, we may perform a preoperative embolization 3 to 6 weeks prior. We can achieve 30 to 50% size reduction, and then we can cryoablate. And that's been a very good way, and Dr. Pak and Dr. Manley will tell you this, that they've referred several patients with larger masses that are not good surgical candidates. Again, here's another case study. There's a 6.1 centimeter left upper pole renal mass. Here's the pre-embolization picture. After embolization, you can see I use some hyperdense particles that maintain themselves in the mass and throughout the mass. It's hard to get a good approximation of the size decrease, but then you can see the ablation here that I'm able to, with true probes, go directly into the mass and freeze across the entire mass. Another indication for ablation are solitary or oligometastatic deposits, or even recurrent disease. So in patients with recurrence in the ipsilateral or contralateral kidney, ablation can be selected. Percutaneous ablation, of course, obviates the need for additional surgery on either side, especially when the resection bed may pose a surgical challenge. In patients with recurrence or mets outside of the kidneys, again, if surgery is not indicated or not preferred, especially for small lesions, percutaneous ablation allows for focal therapy without reoperation and without, quote, using up systemic options. So if you've got a 2 or 3 centimeter recurrence in the renal fossa, perhaps it might make sense to just use focal therapy and wait on systemic options until there's further blossoming of disease. So for example, here you'll see partial nephrectomy right here. recurrence in the bed. I actually microwave this because it's away from other structures. You can see a rim of fat necrosis, and this, of course, was biopsy-proven clear cell RCC. And this rim of fat necrosis you can see on the 14-month follow-up. In addition, there's no further enhancement. What about efficacy and complications after ablation? Well, let's talk about efficacy first. There have been several different studies looking at efficacy of ablation versus partial nephrectomy, ablation versus nephrectomy, et cetera. I think that the rule of thumb truly is at 5 years, there are very similar outcomes, particularly for stage 1A lesions. For stage 1A lesions, you can expect a local recurrence-free survival at 5 years of greater than 5% and a cancer-specific survival of greater than 99%. So what I usually will tell my patients, and I believe Dr. Pak and Dr. Manley would support me in this, is that I say, well, I can expect that less than 5% of patients should have recurrence in 5 years. And that's usually the same for partial nephrectomy. For stage 1B, of course, bigger lesions, they have similar outcomes for partial nephrectomy versus percutaneous ablation, but even still, they're still quite good. So at 5 years, we expect that less than 7% should have recurrence. Older studies demonstrate increased rates of recurrence for percutaneous ablation, but I really do think that as we improve our technology and even as we improve our technique, those rates are going to become closer and closer to partial nephrectomy, depending on the size. Ablation, of course, has a lower rate of hospital stay, and it can sometimes be considered nephron sparing. So in a solitary kidney, ablation may make sense. In terms of the complication rate, again, pretty low complication rate. The takeaway here should be that bleeding and hematuria, which is truly another way of bleeding, really only happen 1 to 3% of the time. Adjacent organ injury should happen less than 1% of the time. And these are, of course, procedure-related complications. I should have said that earlier. I think the way to think about these are procedure-related, that happen immediately after the procedure, and of course, late onset, that might happen weeks to months later. Late onset complications should also be exceedingly rare. Urinomas can happen depending on the size of your ablation cavity. And you can also have cutaneous pain and paresthesia, which, again, only for superficial lesions and only for those ones that are close to the rib or close to the lumbar nerves, the neurovascular bundle, will you experience pain or paresthesia. And typically that pain, if you happen to singe a nerve, goes away at 4 to 6 weeks and results in a little bit of cutaneous paresthesia. So what are the conclusions? Well, percutaneous biopsy of renal masses should be performed when results change management. When results change management, I think that's paramount and key. Percutaneous biopsy of renal masses is safe, with high diagnostic yield and low complication rate. With coaxial techniques, seeding risk is negligible. And when being performed by someone who has experience, diagnostic yield should be very high in the face of a very low complication rate, such as bleeding. Percutaneous ablation represents a minimally invasive technique that has similar oncologic effectiveness at 5 years as partial nephrectomy, especially for small renal masses. And the complication rate for percutaneous ablation is quite low. The final thing I'll say is that we do offer solutions for those cases in which they're larger than 4 centimeters, and that takes true multidisciplinary coordination with your IR and urology colleagues. Thank you so much for joining me today. I hope you enjoyed this presentation. If there are any other questions, I'm happy to take them now.